Good day, everyone. Hope you are having a good day. Today, we will be presenting our case study, which is the cardiogenic shock. Cardiogenic shock is a condition wherein the heart is not able to pump enough blood and oxygen to the brain and the other vital organs, so the cardiac output is not enough to suffice the metabolic demand of the body, which result in inadequate tissue perfusion. And if there is inadequate tissue perfusion, there will be decreased cellular oxygenation, tension, and disruption of normal oxidative phosphorylation with a decrease in the generation of adenosine triphosphate or the ATP. So, if the oxygen-rich blood does not reach the brain and the other vital organs, there will be drop in the blood pressure and the pulse slows. There are four stages of the cardiogenic shock, which are the initial, compensatory, progressive, and the refractory. For the initial stage, there is diminished cardiac output with no clinical symptoms, while in the compensatory, the baroreceptor respond to decreased cardiac output, wherein it stimulates the sympathetic nervous system to release catecholamines to improve the myocardial contractility and the vasoconstriction. And if there is no intervention or if there is failure of intervention for the inadequate tissue perfusion, then that is where the progressive stage occurs. There will be clotting and tissue death because of decrease in circulating volume and increase in blood viscosity. And if there is no effective intervention given, refractory stage occurs in which the chance of survival of the patient is limited. Most of the experts acknowledge that the patient with cardiogenic shock is often unresponsive to treatment, and mortality rate is 20% to 50% if there is medical intervention. In the United States, there are estimated 40,000 to 50,000 people per year who gets cardiogenic shock, and it is higher in patients aged 75 years older. And even though there is use of percutaneous coronary intervention, which helps in reducing the incidence, it still happens in 5% to 8% of patients hospitalized with ST segment elevation, myocardial infarction or the STEMI, and 2% to 3% with the non-STEMI. In the Philippines, statistics from the Department of Health show that the cardiovascular diseases ranked among the top 10 leading causes of morbidity and diseases. It is responsible for the third cause of death in the Philippines. According to the Philippine Statistics Authority or the PSA, cardiovascular diseases are part of the larger group of non-communicable diseases which account for 72% of deaths in the country in 2021, and cardiogenic shock was the most common cause of death at 57.14%. While in Davao City in 2019, Davao City had the highest number of deaths by heart disease such as the cardiogenic shock in the Philippines, Davao region accounting for nearly 2.1 thousand out of over 6.2 thousand deaths across the region. Cardiogenic shock is the top cause of death in people who have heart attack. This disease is considered a medical and nursing emergency. It is often deadly if it is not treated immediately. Next is the definition of terms of cardiogenic shock. Sethi K defined cardiogenic shock as a condition wherein the heart is not able to pump enough oxygen-rich blood to the body organs, wherein it causes chest pain or discomfort in the left arm, trouble breathing, sweating, and fast or irregular heartbeat. While the Mayo Clinic defined it as a decreased cardiac output and evidence of tissue hypoxia in the presence of adequate intravascular volume. And Janet H. defined cardiogenic shock as a state of end organ hypoperfusion due to the cardiac failure and the inability of the cardiovascular system to give adequate blood flow to the extremities and the other vital organs. And the National Library of Medicine defined the cardiogenic shock as a primary cardiac disorder which results in both clinical and biochemical evidence of tissue hypoperfusion. On the other hand, Kellerman R. defined cardiogenic shock as a systolic blood pressure of less than 90 mm per mercury for longer than 1 hour that is not responsive to fluid administration, secondary to cardiac dysfunction or associated with signs of hypoperfusion or cardiac index less than 2.2 liter per minute per millisecond, and pulmonary capillary wedge pressure which is greater than 18 mm per mercury. Lastly, the Merriam-Webster defined cardiogenic shock as a shock resulting from failure of the heart to pump an adequate amount of blood as a result of heart disease and especially heart attack.
Etiology. Cardiogenic shock is a life-threatening condition wherein the heart's ability to contract and pump blood is impaired that results to inadequacy of supplied oxygen for the rest of the body. This condition is most often caused by severe heart attack wherein blood flow through the arteries is restricted or blocked completely, and other heart failure problems such as myocardial infarction, cardiomyopathies, and chest injuries. So other than this, it can also be caused by pulmonary embolism, internal bleeding, and traumatic injuries. So additionally, myocarditis, endocarditis, drug overdoses, poisoning, and a weakened heart rate are included as factors for cardiogenic shock. So furthermore, patients may experience symptoms of rapid breathing, severe shortness of breath, tachycardia, cyanosis on the extremities, and hypotension. So without adequate oxygen and blood circulation, the blood pressure starts dropping, leading to impairment of the brain and other vital organs. So a lack of oxygenation in the body system and the need to supply this adequacy damages the pumping chamber, leading the heart muscle to weaken and go into cardiogenic shock. With patients suffering from cardiogenic shock, they may experience angina, develop dysrhythmias, and hemodynamic instability. So the goal of medical management for this condition is to treat the underlying cause by getting blood flow from circulating properly with adequate oxygenation to the entire body and protecting vital organs from damage. Patient's profile. So our patient is named as Patient X. He is a 75 years old male, Caucasian, and is married with chief complaint of acute confusion and mental status changes, then presented to the emergency room with dyspnea and chest pain. His differential diagnosis was to consider sepsis, malperfusion, delirium, drug overdose, dementia, and other causes. Then his final diagnosis is cardiogenic shock and admitted on October 23, 2022. Present health history. So on October 23, 2022, a 75-year-old patient named as Patient X presented into the emergency room with complaints of dyspnea and chest pain that was sustained despite of rest. So the emergency department ruled in ST elevation myocardial infarction or STEMI, and he was treated medically until undergoing cardiac catheterization. So during his catheterization, percutaneous coronary intervention or PCI was performed including drug-eluting stents to a 99% stenosis of the first diagonal branch of the left anterior descending artery. So the catheterization findings were also significant for diffuse coronary disease, but no other focal lesions were identified or treated. Following the procedure, he was admitted to the intermediate cardiac care floor for observation. Then over the past 3 hours, it was noted that he was less interactive and intermittently confused. So this confusion appears to be worsening, with the patient in great emotional distress at times. So attending physician was called the following day due to patient chief complaints of related to acute confusion and mental status changes. So on arrival to the bedside, the doctor notes a confused elderly male in apparent emotional distress with blood pressure of 105 over 65 millimeter per mercury with mean arterial pressure of 78 and temperature of 98.9 degree Fahrenheit or equivalent to 37 degrees Celsius, which is normal. Then pulse rate of 110 beats per minute, respiratory rate of 24 breaths per minute with oxygen saturation of 99% and finger stick blood glucose of 105 milligrams. So, on physical examination, confusion assessment method or CAM was positive due to inattention and disorganized thinking. Then tachypnea was noted but with synchronous respiratory pattern. Then hypoactive bowel sounds, tympanic on percussion, nail beds are pale, extremities are cool to touch with capillary refill of 3 seconds and mottling of the bilateral lower extremities.
For the past medical history of the patient, based on medical record in his son, the patient have hyperlipidemia, hypertension, osteoarthritis, seasonal allergic rhinitis, and for his hyperlipidemia, it controlled with diet and exercise. For his hypertension, it managed with hydrochlorothiazide. For the social history of the patient is a retired car salesman, currently lives with his wife, smoked occasional cigar as young man but stopped 40 years ago, social alcohol intake at 1 to 2 drinks per week, and no illicit drug use. For the family history, since he was adopted as a child, so he doesn't know about his family medical history. And the patient has no drug or food allergies.
For the physical examination, vital signs, the temperature is 98.9 degree Fahrenheit, which is taken orally, pulse rate of 110 beats per minute, respiratory rate of 24 breaths per minute, and a blood pressure of 105 over 65 millimeter mercury with mean arterial pressure of 78. For other tests, oxygen saturation is 99% on room air, finger stick blood glucose of 105 mg per deciliter. For the neurological examination, the patient is oriented to person but not to place or time. He states that the healthcare team members are intruders in his home, not combative or agitated, inattentive during examination, and the CAM or the confusion assessment method is positive due to inattention and disorganized thinking. The strength and sensation are grossly intact in bilateral extremities. Face is symmetric and no facial droop is noted. For the hint examination, the head is normocephalic and atraumatic. Eyes, pupils are equal and reactive. For the cardiovascular examination, heart rate and heart rhythm is regular, no murmurs, no gallops. Jugular venous distension is present at 45 degree head elevation. For the pulmonary examination, tachypnea is present but synchronous respiratory pattern. Cleared auscultation from apexus to basis. Gastrointestinal examination, hypoactive bowel sounds, tympanic on percussion, abdomen is soft without masses and non-tender. For the extremities, nail beds are pale, extremities are cool to touch, capillary refill within 3 seconds, mottling of the bilateral lower extremities is noted.
Anatomy and physiology. Anatomical structures and physiology of the affected body organ or system. So the cardiovascular system, which consists of the heart, blood vessels, and blood, is responsible for the transport and delivery of nutrients and oxygen-rich blood to the entire tissues via the arterial system channel, which branches into smaller blood vessels from arteries to arterioles to capillaries, carrying the oxygenated blood back to the lungs through the venules and vein channels. So the heart, which is the most vital organ of the system, pumps blood circulation to the entire body, functions to manage the blood supply, contracts to produce blood pressure, secures a one-way blood flow, and transmit blood. So in addition, there are two blood circulatory within this system, namely a systemic circulatory system, which transports blood to the organs and tissues throughout the entire body, and the pulmonary circulatory system, which moves blood between the heart and lungs. So moreover, the heart is composed of three layers, named as the epicardium, which is the visceral and the outermost layer of the heart wall that protects the heart and provides signals for embryonic heart formation and maturation, helps injury response and regeneration. Then myocardium, which is the muscle of the heart, consisting of thick fibers that are twisted and whirled, responsible for contracting the heart. So this is the middle and the thickest layer of the heart, keeping it to pump the blood throughout the body. Next is endocardium, which is the innermost layer, which lines the chambers of the heart, provides protection to the valves and the heart chambers. Furthermore, the heart has four hollow chambers, which consists of two atria and two ventricles. So the right atrium receives the oxygen-poor blood from the body and pumps it towards the right ventricle, wherein the latter pushes it to the lungs for blood oxygenation. Then the left atrium receives the oxygen-rich blood from the lungs and pumps it towards the left ventricle. The superior and inferior vena cava receives oxygen-poor blood from the veins and then pumps it to the pulmonary trunk. Then the pulmonary arteries carry blood to the lungs, and the pulmonary veins that drains oxygen-rich blood from the lungs. Lastly is the aorta, which is the systemic arteries branch to supply the entire tissues and the rest of the body. In addition, the heart is composed with four valves, wherein it allows blood to continuously flow in one direction through the chambers. The atrioventricular valves, or the AV valve, prevents backflow into the atria during contraction of the ventricles. The bicuspid, or the mitral valves, allows blood flow from the left ventricle to the aorta, preventing it from flowing backward. Then the tricuspid valve allows blood flow to the right ventricle, where it is further pushed towards the lungs for oxygenation. Then lastly, the semilunar valve determines the passage of blood between the ventricles and the main arteries, wherein it transports blood away from the heart towards the entire body system.
For the pathophysiology, in our case, the etiology of cardiogenic shock is unknown. The patient is at risk of cardiogenic shock because of his age and because he was adopted, causing his family history to be unknown. The patient has a history of hyperlipidemia and hypertension and smoke at a young age. Since the patient has a history of hyperlipidemia that causes increased fatty deposit in coronary artery that causes blockages, maybe that's the reason why an acute ST elevation myocardial infarction occurred due to the occlusion of the coronary artery of the patient. Since there was a STEMI, the heart of the patient can produce enough blood to the body and organs. because the heart is the main centerpiece in the body that plays a role in tissue perfusion, and everything in the body depends on the heart for its survival.
If the heart can pump blood efficiently, the organs do not receive enough oxygenated blood, and the cells that make up that organ start to fail. Therefore, the patient's heart is unable to pump, leading his cardiac output to decrease. This decreases tissue perfusion, which prevents the patient's organ cells from receiving enough oxygen to function. The patient experienced confusion, increased respiration rate, dyspnea, and chest comfort as a result. Due to cell damage in organs that were beginning to fail, the patient suffered from a cardiogenic shock.
Good morning, everyone. My name is Ninalyn F. Pilawan, and I will be discussing the nutritional and surgical management in this case. Cardiogenic shock is a condition wherein our heart cannot supply enough blood to keep the body function properly. A variety of risk factors can increase the risk of developing heart disease, which can eventually lead to cardiogenic shock. And on this case, patients' past medical history reveals hyperlipidemia, hypertension, and alcohol intake, which possibly triggers the patient to experience cardiac shock. Making lifestyle changes to maintain a healthy heart and low blood pressure is the best way to prevent cardiogenic shock. Diet plan on this patient include dietary approaches to stop hypertension or DASH diet. This diet is a healthy eating plan that is designed to help treat or prevent hypertension. It includes foods that are rich in potassium, calcium, and magnesium. Hence, foods that are high in sodium, saturated fat, and added sugars are limited in this diet. When following DASH, it is important to choose foods that are rich in potassium, calcium, magnesium, fiber, protein, and low in saturated fat. These foods include avocados, bananas, potatoes, dairy products such as cheese, yogurt, and skim milk, beans and lentils, whole grains and dark green leafy vegetables, lean beef, and fish. On the other hand, it is important to reduce sodium by using sodium-free spices or flavorings instead of salt, not adding salt when cooking rice, pasta, or hot cereal, choosing plain, fresh, frozen, or canned vegetables, choosing fresh or frozen skinless poultry, fish, and lean cuts of meat, and reading food labels and choosing low sodium or not salt added options. In here is an example of a DASH diet which may help our 75-year-old Caucasian male patient with regards to his hypertension. For his breakfast, we have 1 whole wheat bagel, 2 tablespoons of fat-free cream cheese, 8 ounces of skim milk, 4 ounces of orange juice, and 1 cup grapes. For his lunch, we have 2 slices of whole wheat bread, 1/2 fat-free cheese, 1 tablespoon of mayonnaise, 2 ounces of sliced roast beef, 1 cup steamed baby carrots, 1 fresh peach, 4 ounces of grape juice. For his dinner, we have 3 ounce baked chicken breast, 1 cup steamed rice, 1 cup steamed asparagus, 1 cup sauteed spinach, 1 medium apple, and glass of water. For his snack, we have 1/2 cup of unsalted nuts and 1/2 cup of unsalted pretzels. According to American Heart Association, reducing the consumption of saturated fat and trans fat is the best way to lower the cholesterol in the blood. On the other hand, fruits, vegetables, whole grains, fat-free or low-fat dairy products, lean proteins, high-fiber foods while limiting red and processed meats, sodium, and sugars within food and beverages were all part of a heart-healthy diet in which it helps the patient lower his high cholesterol or hyperlipidemia. In here, we have created an example of a meal plan which help him control his hyperlipidemia. For his breakfast, we have 1 cup low-fat plain Greek yogurt, 2 whole wheat toast, 2 tablespoons of fat-free cream cheese, 1 medium apple, and 1 cup skim milk. For his lunch, we have 1 bowl of kale and avocado salad with blueberries and edamame, 1/2 cup of unsalted nuts, 1 plain water, and 1 cup of frozen berries. For his dinner, we have 4 ounce poached salmon with asparagus, 1 cup of brown rice, 1 banana, and 1 cup of pomegranate juice. For snack, we have 2 tuna salad with smashed avocado on rye crisps, 1 sliced carrot, cucumber and celery dip in hummus, and 1 cup of grapes. Next is the surgical management. In this case, the patient was treated medically until undergoing cardiac catheterization. During his catheterization, percutaneous coronary intervention was performed, including drug-eluting stents to a 99% stenosis of the first diagonal branch of the left anterior descending artery. What is percutaneous coronary intervention, or PCI? It is also known as angioplasty with stenting. It is a minimally invasive procedure used to open a blocked coronary heart artery. In this procedure, a small balloon along with stent or a tiny mesh tube is being inserted into the problem of area, which in this case on the left anterior descending artery to keep it open following the removal of the balloon. Before the procedure, patient was given a sedative to help them relax. In such cases, the hair in the groin will be clipped and an IV line is inserted. If any problem arises, medication will be given quickly. Electrodes will be attached to monitor the heart of the patient and pulse oximeter to track oxygen level in the blood either in finger or on the ear. During percutaneous intervention, an assigned interventional cardiologist who specializes in the heart, blood vessels, and circulatory system makes a small insertion and reach a blocked blood vessels, either in the arm or the groin. Then, using an X-ray that shows real-time image in the monitor along with a contrast dye, a non-harmful solution that appears well on medical imaging is injected and used, and a catheter is then threaded through the blood vessel of the heart where the coronary artery is narrowed. When the tip is placed, the balloon catheter with a stent is advanced over the wire to the blockage site. Moreover, the balloon tip compresses the plaque and expands the stent. The balloon is then deflated and withdrawn. Once the plaque has been compressed against the artery wall, the stent will be placed. Nowadays, the majority of stents have coatings that gradually release specific medications called the drug-eluting stent, used to stop the development of the formation of scar tissue in the artery, further ensuring proper blood flow and minimizing the need for additional medical intervention. Additionally, the stent stays in the artery to keep the blood vessel open. Once done, closing of the insertion site is performed to stop the bleeding with a compression bandage. On the other hand, if the insertion is placed in the groin area, patient needs to lie flat on their back for several hours, keeping legs straight. And if a catheter was inserted into the arm, pillows and a stabilizing board will be utilized to keep the arm elevated and keep straight. This procedure only takes between 30 minutes and 2 hours to complete. The precise treatment time is determined by a number of factors, including the extent of plaque buildup. After the procedure, patient is advised to stay in the recovery area for observation. Bruising, soreness in the insertion site is expected. If patient feels discomfort, a pain medication is given, and patient is encouraged to drink water to flush out the contrast dye from the body.
Hello everyone, I am Lizelle Jane Agbo and I'll be discussing about the actual and potential nursing care plan of the patient with cardiogenic shock. The next actual nursing care plan is when it comes to assessment. Under the assessment is a subjective, which is none. Objective data is tachycardia, dyspnea, nail beds are pale, extremities are cool to touch, capillary refill is 3 seconds. So the vital sign as taken, heart rate is 110 beats per minute, blood pressure is 105/65, RR is 24 beats per minute, and lastly, body temperature is 37.16 degrees Celsius. So the diagnosis for this is ineffective tissue perfusion related to reduction of blood flow as evidenced by tachycardia, dyspnea, capillary refill of 3 seconds. So the objectives and planning is that at the end of my 1-hour nursing intervention, the client will be able to maintain an adequate tissue perfusion as evidenced by stable normal breathing pattern, heart rate, and less than 2 seconds of capillary refill.
So when it comes to intervention and rationale, the first thing that the nurse must do is to build rapport to the client, this to gain cooperation of the client. The second one is the nurse must assess the client's heart rate, blood pressure, and pulse pressure. Use direct intra-arterial monitoring as ordered. This to maintain an adequate cardiac output. Sinus tachycardia and increased arterial blood pressure are seen in the early stages. As the situation worsens, the blood pressure drops due to the vasoconstriction. Auscultatory blood pressure may be unreliable. Shock causes a decrease in pulse pressure. Next is that the nurse must assess for any changes in the level of consciousness. This because restlessness and anxiety are early signs of cerebral hypoxia, while confusion and loss of consciousness occur in the later stages. Next is that the nurse must assess capillary refill. This to identify if capillary refill is low or absent. Next is that the nurse should monitor oxygen saturation and arterial blood gases. This to monitor oxygen level of the patient. The oxygen concentration is measured using pulse oximetry. The normal oxygen saturation level should be 95% or higher because as the shock progresses, aerobic metabolism stack and lactic acidosis develop, resulting in an increase in carbon dioxide and a decrease in pH. Next is that the nurse must restrict the patient's activity and maintain client on a bed rest. This to minimize oxygen demand by maintaining bed rest and limiting the client's activity. Next is that the nurse must provide oxygen therapy as indicated. Oxygen is administered to increase the amount of oxygen carried by available hemoglobin in the blood. Lastly, administer IV fluid as ordered. Sufficient fluid intake maintains adequate filling pressures and optimizes cardiac output needed for the tissue perfusion.
Lastly, the evaluation is that goal met. At the end of my 1-hour nursing intervention, the client is able to maintain an adequate tissue perfusion as evidenced by stable normal breathing pattern, heart rate, and less than 2 seconds of capillary refill. Next is the potential nursing care plan. So the first potential nursing care plan, so the assessment, under the assessment is the subjective data, which is the healthcare team member are intruders in my home as verbalized by the client. The objective data is that neurological, the patient is oriented to person but not to place and time. So the diagnosis for this is that risk for injury related to confusion, impaired decision making as evidenced by disorientation to time, place, and circumstances.
So when it comes to intervention and rationale, the first thing that the nurse must do is to build rapport to the client, this to gain cooperation of the client. Next is that the nurse must eliminate or minimize source of hazard in the environment. An environment that is free of hazard allows maximum patient independence and a sense of autonomy. Next is that the nurse must instruct family regarding the removal or locking up knives and sharp objects away from the patient. This include cleaning supplies, this to prevent physical injury from ingestion, burns, overdoses, or accidents. Next is that the nurse should instruct family to keep pathways clear, move furniture against the wall, remove small rags, remove wheels on beds and chair or lock them in place. This to prevent the risk of fall. Next is that the nurse must encourage caregiver or family member about patient reorientation. Teach prospective caregivers or family member how to orient client to time, person, place, and circumstances as required. These caregivers and family member will be responsible for client safety after discharge from the hospital. Next is that the nurse must enforce the positive feedback. Positive feedback increases self-esteem and enhances desire to repeat appropriate behavior. And lastly, the nurse must explain simply. When communicating with client, use simple explanation and face-to-face interaction. Do not yell the message into client's ear. When communicating with an elderly person who has a hearing loss, speaking slowly and in face-to-face position is most effective.
Evaluation for this is that goal met. At the end of my nursing intervention, patient remained in a safe environment with no complication or injuries obtained and orientation to time, place, and circumstances. Under the assessment is the objective data, which is patient does not like to see his primary care provider and often has avoidant health behaviors. So the diagnosis for this is risk for anxiety related to change in health status as evidenced by uncooperative behaviors. The objectives or planning for this is at the end of my nursing intervention, the client will be able to acknowledge and discuss fears and concerns.
So, intervention and rationale. So, the first thing that the nurse must do is to build rapport to the client. This to gain cooperation of the client. The next is that the nurse must assess previous coping mechanism used. Anxiety and ways of decreasing perceived anxiety are highly individualized. Intervention are most effective when they are consistent with the client established coping pattern. Next is that the nurse must assess the client's level of anxiety. Shock can result in an acute life-threatening situation that will produce high level of anxiety in the clients as well as in the significant others. Next is that the nurse should explain all procedure as appropriate, keeping explanations basic. Information help reduce anxiety. Anxious client unable to understand anything more than simple, clear, brief instruction. Next is that encourage the client to verbalize his or her feelings. Talking about anxiety producing situation and anxious feeling can help the client perceive the situation in a less threatening manner. Next is that the nurse must acknowledge an awareness of client's anxiety. Acknowledgement of the client's feeling validates the client's feelings and communicate acceptance of those feelings. Next is that the nurse must reduce unnecessary external stimuli by maintaining a quiet environment. Anxiety may escalate with excessive conversation, noise, and equipment around the client. And lastly is that the nurse must assess client's vital signs. Patient's vital sign may be abnormal if feeling anxious. Example, tachycardia and tachypnea may be present.
Is goal met. At the end of my nursing intervention, the client is able to acknowledge and discuss fears and concerns.
So next is, we have here another actual nursing care plan. So for the assessment cues, we only have objectives. So chest pain, tachypnea, jugular vein distension, and vital signs, which is pulse rate is 110 beats per minute, blood pressure is 105/65 millimeter of mercury, and 78 MAP. And we also have here the respiratory rate, which is 24 cycles per minute. So for the nursing diagnosis, decreased cardiac output related to impaired left ventricular contractility as evidenced by chest pain, tachypnea, jugular vein distension, and vital signs, which is the pulse rate 110 beats per minute, the blood pressure 105/65 millimeter per mercury, and MAP 78, and the respiratory rate, which is the 24 cycles per minute. So for the objectives, within my 2-hour span of care, the client will be able to relieve from chest pain, maintain adequate cardiac output as evidenced by pulse rate 110 beats per minute, BP 105/65 millimeter of mercury, and respiratory rate 24 cycles per minute.
Next is the nursing intervention. For the independent intervention is, first assess the heart rate and blood pressure, because sinus tachycardia and increased arterial blood pressure are seen in the early stages. BP drops as the condition deteriorates. Second is assess the peripheral pulses. Pulses are weak and with reduced cardiac output. Third is assess for the client for chest pain. It indicates an imbalance between oxygen supply and demand. Fourth, assess the cardiac rate, rhythm, and electrocardiogram or the ECG. The 12-lead ECG may provide evidence of myocardial ischemia or the ST segment and T-wave changes or the pericardial tamponade or decreased voltage of QRS complex. Fifth is place the patient to semi-Fowler's position. This is to help the patient ease his breathing. Sixth is encourage the client to relaxation techniques such as deep breathing as breathing exercise. This is to reduce anxiety and conserve energy. And for the collaborative intervention is administer medication as prescribed by the physician. noting the response and watching for side effects and toxicity. It's depending on the etiological factors, and common medication include digitalis therapy, vasodilator therapy, antidysurrhythmics, ACE inhibitors, and inotropic agents. Next is administer humidified oxygen as ordered. The failing heart may not be able to respond to increased oxygen demands. Third is measure the height of the bulge or distension of the jugular vein. Ask the patient to lie down on the exam table with the head at 45 degrees. So the physician will measure the height of the bulge of JVD to indicate the CVP. And lastly is maintain the hemodynamic parameters at prescribed levels. For the patient in the acute setting, close monitoring of these parameters guide titration of fluids and medication. And for the evaluation, after my 2-hour span of care, the client was able to, first is relieved from chest pain. Second is maintain adequate cardiac output as evidenced by strong peripheral pulses, heart rate of 60 to 100 beats per minute within the regular rhythm, and the systolic BP within 20 mm of mercury of baseline.
Good day, everyone. Next would be the client's health education. First, explain the effects of shock on all body system to the patient and the family so that they will understand the seriousness of the illness. Next is to teach the client about medications he may be maintained on. Third, encourage the client to maintain a healthy weight because being overweight contributes to other risk factors for heart attack and cardiogenic shocks such as high blood pressure, cardiovascular disease, and diabetes. Losing just 10 pounds or 4.5 kilograms can lower blood pressure and improve cholesterol levels. Next is to encourage the client to be physically active, such as doing aerobic exercise. Most older adults need about 2.5 hours of aerobic exercise, just like brisk walking every week. That's about 30 minutes on most days. Endurance exercise like walking, dancing, and playing tennis help the breathing, heart rate, and energy to improve. Next is to teach the client to practice heart healthy eating with the DASH or dietary approaches to stop hypertension eating plan. A heart healthy eating plan includes fruits, vegetables, and whole grains and limits saturated fats, sodium or salt, added sugars, and alcohols. Next is to teach the client to limit alcohol intake, and if the client chooses to drink alcohol, do so in moderation. For healthy adults, that means up to 1 drink or a day for women and up to 2 drinks a day for men. Next is teach the client to eat less cholesterol and saturated fat. Limiting these, especially saturated fat or bad fats that comes from animal sources such as butter, cheese, and fatty meats can reduce your risk of heart disease. Also, teach the client to avoid eating trans food that contains trans fats. Next is to encourage the client to eat leaner, lower fat, and skinless meats instead of fatty cuts of meat and chicken with skin. To consume and to encourage the client to consume lower fat dairy products instead of whole milk and use certain vegetable oils such as olive and canola oil instead of butter, lard, and coconut and palm oils. Next is to inform the client of the need of minimizing added sugar foods and beverages. This will help the client to avoid nutrient-poor calories and help him maintain a healthy weight. Next is encourage the client about the importance of managing stress. Learning how to manage stress, relax, and cope with problems can improve their emotional and physical health.
Lastly, inform the client to seek immediate medical attention if he is having any symptoms that may reflect a heart attack. If symptoms of heart attack is present, call 911 or other emergency medical services for help. If you don't have access to emergency medical services, have someone to drive you to the nearest hospital and don't drive yourself.
Next is the prognosis. It refers to determining the predicted or probable level of improvement and function, and the amount of time needed to reach the level of improvement in a health condition. There are 7 criteria in prognosis, and these are the onset of illness, duration of illness, precipitating factors, mood and affect, attitude and willingness to take medication and treatment, depressive features, and lastly, the family factors. First criteria is the onset of illness. We categorize it to good, which is 3, because the client was treated medically and underwent a cardiac catheterization, and the catheterization findings are diffuse coronary disease, but no other focal lesion was identified. He was admitted to the intermediate cardiac care floor for observation. So there are medications specifically to treat her current illness, and these are the aspirin, hydrochlorothiazide, and the ibuprofen for his osteoarthritis. Next criteria is the duration of illness. We categorize it to fair, which is 2, because the client was a past medical history of hypertension and hyperlipidemia and was admitted with dyspnea on exertion and chest pain worsening over 6 months. The client smoked occasionally cigars as a young man, but he quit 40 years ago, and he also intakes alcoholic beverages at 1 to 2 drinks per day. Next is the precipitating factors, and we categorize it to fair, which is 2, because the precipitating factors engaged by the client are high blood pressure and hyperlipidemia with dyspnea and chest pain. Next criteria is the mood and affect. We categorize it to poor, which is 1, because upon arriving at the client and upon the observation of the doctor, the client is confused and emotionally distressed. Next criteria is the attitude and willingness to take medication and treatment. We categorize it to poor also because the client is oriented to person but not oriented to time and place. He also states that the healthcare provider is the intruder in his home, and during the examination he is inattentive, and he is positive to CAM or the confusion assessment method due to inattention and disorganized thinking. Also, the client is not cooperating well in the treatment procedure because the client does not like to see his primary provider and often has avoidant health behaviors as noted by his spouse. Next criteria is the depressive features. We categorize it to good, which is 3, because the client is not experiencing depression. And lastly is the family support. We categorize it to fair, which is 2, because the client was accompanied by his son and currently living with his wife. And for the interpretation, the highest score rate of the client's prognosis is 42.86%, which is fair category. Because the duration of the illness of the client is fair, the precipitating factor of the client engaged is high blood pressure, hyperlipidemia with dyspnea and chest pain. And the family support is also fair because he accompanied by his son and currently living with his wife. The onset and the duration of the illness of the client are fair. While on the other hand, the 28.57% is both the good and the poor categories. In the good category, the onset of illness is good because his disease is immediately diagnosed. In depressive features, the client is not experiencing depression. In the poor category, the mood and affect are poor because the client is confused and in emotional distress. And the attitude and the willingness to take medication and treatment are also poor because the client is not oriented to time and place. He also states that the healthcare provider is intruders in his home, and during the examination, he is inattentive and positive to CAM due to inattention and disorganized thinking. Also, the client is not cooperating well in the treatment procedure because the client does not like to see his primary provider and often has avoidant health behaviors as noted by his spouse. And overall, there is a total of 100%.
So next is the evidence-based nursing practice, which is about management of cardiogenic shock complicating acute myocardial infarction. So in the absence of intravascular hypovolemia, cardiogenic shock is a condition where there is a decreased cardiac output and end organ hypoperfusion. So cardiogenic shock is a medical emergency, so clinical results may be impacted by a high index of suspicion, quick diagnosis, and fast start of therapy, including transferring patients to a tertiary cardiac centers. So additionally, cardiogenic shock might appear at any point during the patient's sickness, usually soon after admission to the hospital. So the electrocardiographic alterations of myocardial infarction with symptoms of cardiogenic shock and the history of chest discomfort will corroborate the diagnosis. So the mortality rate for patients who present with an acute myocardial infarction complicated by cardiogenic shock has remained extremely high, and there are few effective treatments available. So this is true despite improvements in percutaneous coronary interventions and their widespread use. So many of the commonly utilized methods in treating these people are supported by scant data. So in this article, we include general information about cardiogenic shock complicating myocardial infarction, as well as an update on the current range of treatment choices such as inotropes and vasopressors, coronary revascularization, mechanical circulatory support devices, mechanical complications, and long-term results.